Well, can you nod, Mohini, if you can hear me? Okay, good. I am just super excited to be able to present with the AIUM and the APTA. My name is Greg Fritz, and I am thrilled to share the mic with such accomplished professionals as Dr. Sions and Dr. Steiner and Dr. Rawat. I will tell you, though, I'm probably the older and the maverick one of the group. I am practicing in a small town in the Northwest, and I'm a physical therapy practice owner. I have, in fact, been a physical therapist for 35 years, and over the course of those 35 years, I have developed the present network of clinics that I have in the Pacific Northwest. And I hope that you can go with me over the course of the story in my presentation. I'm going to tell you a little about who I am, what I'm doing, but more important than any of that is I would like to motivate within you a desire to do what I'm doing, or at least a desire to get involved in seeing what musculoskeletal ultrasound imaging can do to your practice. Because though I do have 4 clinics within the island group north of Seattle and south of Vancouver, Canada, I actually am nearly 100% of the time doing traveling diagnostic point-of-care imaging as a sonologist. And I provide this imaging services to my own clinics, to colleagues' clinics. I contract with some of the remote medical community care centers, also with occupational medical clinics and urgent care centers. And I scan about 3 days a week, and then I do reporting 1 day a week. But I want to take you along with me on one particular day. And you'll see my commute up here in the Pacific Northwest. I am absolutely thrilled to be able to make use of my flying skills. And I have a 182 that on good weather days, those of you who know the Pacific Northwest know that that is limited, but I am able to fly to the communities that I represent. And I would like to have you go along with me on one particular flight. It seems a little loud to me. Let me back that down just a bit. And you'll notice how embarrassingly close my house is right here. And you'll notice coming up in the next part of this little warped voyage, these are the petroleum refineries that I do some imaging for. My community is Anacortes, Washington, and my clinic is in that community. And this whole island chain is called the San Juan Archipelago. And today, I'm actually going, on the day of the video, I'm going to deliver musculoskeletal imaging diagnostic services to Andrew and Scott, who are the owners of the Orcas Island Physical Therapy Clinic, directly ahead of us on this trip. Orcas Island is the largest, at least in landmass, of the 170 plus named islands in the San Juan chain. You think that I'm doing kind of a travelogue for the San Juan Islands. However, the last slide that Rohini had about remote access, the people, the 5,000 people on Orcas Island, do have a very adorable medical clinic, but they only have access to soft tissue imaging about once a month. And it takes close to 3 to 4 hours to queue in the ferry, take the ferry ride, and get back to the mainland where MRI services are actually delivered. And along with that, it's about $75 for round trip. So here I am landing at the East Sound Airport, and from there, I will pull out of my airplane a folding red wagon. And yes, this, you might say, not athletically built gentleman will pull this red wagon from his airplane along with other items, including my scanner, to these clinics that I represent and provide care to. That would be me. That would be my airplane. And in just a second, you'll be able to see the distance. It's about a half mile that I commute, at least on foot, to deliver this services to my buddies who have their outpatient clinic on Orcas Island. And I'm absolutely thrilled to be able to do it. Isn't that an adorable clinic? Anyway, here's a picture in the distance. These are all Canadian Rocky Mountains, over here. And though I'm all excited about being able to fly to work, those of you who know the Pacific Northwest know that most of the times, certainly in winter, I'm queuing on the Washington State ferries right here and taking that sometimes 14 to 16-hour trip on my own to provide this service. Here are pictures of the way I set up my imaging services at these different clinics. I actually have my scanner that's very portable and used just in operatory or one of the rooms in the physical therapy clinic or the doctor's office. And now I want to get to how I got here, because I want you to realize you can do this too. And I look back to a pivotal event that really got me interested in this, and it was in 1996 that I saw my son moving around in utero. And I noticed that you could see things like vertebrae. And in his particular case, his little hand came up, and I saw the phalanx, and I saw the tissue. And I said to myself, that's through the skin, that adipose layer, the abdominal muscles, through the gut, all the way down to there. Why aren't we in practice using this information? And those of you who are astute out there will look at this particular video. I did not have a video of my son in utero. This was actually taken about 5 weeks ago and is of a chocolate lab that I imaged to see how many babies there were in a friend of mine just recently. However, I also had the possibility of making use of what Malcolm Gladwell calls the outlier opportunity. I had a very generous uncle who was involved in innovating in at least the cardiovascular space with a company called Sonocyte. And so he had devices that he chose one day to hand down to me. And he said, here, let's see what you can see in musculoskeletal tissue. And so sure enough, I grabbed that device and I started looking at absolutely everything. I was trying to match the echo texture of what I saw under that probe to build that proverbial 10,000 hours. And my kids were not safe. In fact, I paid them to watch Gilligan's Island while I put goo on them, along with an anatomy book. And I explored just what in the world anatomy looked like. And as I started to perfect my own personal confidence, I got access to the medical packs and used it on patients. And comparing those two was very, very valuable to me. So after spending quite a few years involved in my own exploration and pursuits, I was able to sit and pass the Pioneer RMSK credentialing exam with 2 other therapists nationwide. And I was also able, in a unique position, to represent the APTA to the AIUM stakeholders board table in 2014, where not with ease, after long discussions, physical therapists were acknowledged as having the ability to become independently credentialed as MSK providers. So with that in place, I continued at the time to do as much learning as I could. But at that time, most of it was through interventional type focus. We did not have the beauty of what we have today. And today, there's many even physical therapy owned and developed curriculum that you can learn how to do these scans, these diagnostic scans within our own profession and how it fits into the way we practice our own form of physical medicine. I continued along doing what I call moving the glass bottom boat scanner over known anatomy. And I learned echo texture and I watched it move and I kept finding stuff. And in the next 4 case studies, I hope you'll be able to see that what I evolved into was a recognizer of echo texture and how that applies to anatomy. These first case studies don't even actually involve our area of expertise. This first one I'm calling Stand Still Hans, because Hans is the son I saw in my wife. And Hans at age 11 came in from swimming in a lake in Idaho. And my uncle had literally given me 5 minutes earlier my first ultrasound scanner. And on my wrist was gel. And I had just got through looking at my flexor tendons, looking at my own carpal tunnel. And Hans made the mistake of walking into our cabin. And I said, hey, stand there and stand still. And so I squirted some gel on him and I put the probe over the gel, and behold, this is what I saw. Now, as you look at that and you start to gather the information that this may provide, it certainly is dark and it looks round, but I will bring up a slide that I stole from Dr. Rawat's presentation, which to me said it all. Your eyes are only able to comprehend what your mind is prepared to comprehend. So another way of saying that, which we see sometimes in training classes for musculoskeletal imaging, is that you see what your eyes are looking for, and you look for what you know, but you know what you spend time learning. So I'll put that particular picture back up there, and I'll kind of briefly walk through this with you because I need to hurry up. This is a round thing on my sun. In there, there's this reflective, almost football-shaped thing, and over the top is this glass domed thing. But it isn't until your mind allows me to put a diagram of the human eyeball in front of you that you realize how abusive a father I was to put gel in front of this poor kid's face and say, stand there. And you'll actually be able to see the lens now, and you see the cornea, you see the ciliary bodies, and your mind opens up the fact that there's actually an optic disc on the back of this, all because we were willing to learn from the echo texture. And it brings up a point I want to make, and that is that there's this possibility that occurs, according to this author here in the book, Where Good Ideas Come From. It's called the adjacent possible, and that is as your mind and your brain begins to understand what it's expanding to see, you can reach out and see other things that you're capable of doing or seeing or understanding. And I want to encourage you to realize that as the more you scan, the more you'll be able to come up with windows that'll help you be able to get a better view into what you're actually wanting to see. So this next case I'm calling the adjacent possible. And all of my friends knew I was wacko for ultrasound imaging when I got this phone call that said, hey, Greg, is there a chance you could use that scanner to count how many of the puppies are inside of Meg, our chocolate lab? And I told Aubrey, look, I can try, but you don't hold me to it. And I, of course, scurried off and looked at my anatomy, and I realized that the dog's uterus is like a wishbone. It's got little places that you have to go and look all around in. And this is literally the scan of Meg. This was a number of years ago. And you can see that first part, you saw one little baby, and you see another two like they're in bunk beds together here. But how in the world is somebody supposed to count this as they're going through it? So I just said, I think there are 7. However, 4 weeks later, I get a phone call from Aubrey, and it said, hey, Greg, Meg's delivered only 5 puppies, and it's been 4 hours. Can you come over and check her? And I go, oh, crud. So I got my scanner out and I drove over there, and I said, look, I told you you can't hold me to 7. But what was really amazing, and it just blew me away because I wasn't prepared for it, is that when I placed the scanner over Meg's stomach, I was able to actually see 2 more puppies. And in her birth canal, there was a non-viable puppy that was so deformed it could not be delivered. And as I worked myself up, I could see a final baby, a puppy, inside of her, and I could literally see that heart beating, all the while gathering the echo texture that would allow me to be able to say, oh, that's what bones look like. That's what a heart looks like. And so about an hour later, because we knew the vet, Meg had a cesarean section done, delivered the healthy baby behind her, and this is a picture of Meg and her 6. You can see one hidden in the middle underneath there. Now, I would like to make it a little bit more relevant to physical therapy as I share with you case study number 3, and that is of a patient who actually had severe wrist pain. And I got the order from the orthopedic surgeon that said, Greg, we need to get this wrist moving. It's been 9 weeks since I did the ORIF, and it's not moving how we want it. So I did a hands-on evaluation. Never avoid that, and we'll get into that here in just a bit. But she had this unique presentation. This is as far as she would let me take her wrist into flexion. Her pain was located right about here. She could not actively extend her hand without severe pain, but oddly, I could extend her hand passively, completely without discomfort. So I put the probe on her wrist in a crosswise fashion, and I moved that probe up and down in what we call kind of an elevator scan. And what I saw was this. Let me give you some context so you can work with me through this one again. This is the back of her wrist. In fact, this little line right here is probably the distal radius. This is the bone. And this is the second dorsal wrist compartment. And those of you who know that, that's the extensor carpi radialis tendons. This is the extensor carpi radialis longus tendon, and right next to it is the extensor carpi radialis brevis. Now, this compact fiber that we're looking down in short axis should be the same over here in the ECRB, but it was darker, and I could even see that this whole tunnel was filled with fluid, and I saw this odd, dense-shaped echo in the extensor carpi radialis brevis. So I simply took the probe, turned it 90 degrees, and I saw that here again is the extensor carpi radialis brevis. Here is the bone profile, and here's fluid over the top of it showing reactive inflammation. And going right into the ECRB were 2 perforating screws. Now, I hate to see in my own mind how I would have tried to motivate this lady to go into active movement, how I would try to facilitate getting her function back. But I just can't get my head around the amount of time and money I was able to save in making sure this got elevated rapidly to surgical intervention. I want to share with you just a little bit about how the traditional process goes for getting information and getting images acquired. Normally, we have to ask, hey, we need this image done, or we need this referral sent to PM&R or orthopedics. Then the insurance has to give us that approval. And then we need to schedule that. And for my patients, just going in to get that scheduled can be a 3 to 4 hour one-way trip, not to mention the expense of it. So just getting these images acquired, or at least on the queue to have acquired, can take up to 2 weeks to do. Now, that's just getting the images. If we want the information back from those images, we then have the radiologist or the specialist provide their narrative. That narrative then gets sent to the doctor's office. That report then gets triaged by the MA, and that patient either gets called with the findings and they're fairly normal, or they get scheduled with their PCP visit. At which time I see those patients and they either tell me what they were told or read to over the phone, or I have the convenience of getting onto PACS. However, this whole process can take up to 7 days. That's the traditional process, but I want to have you at least put into your mind what happens if musculoskeletal ultrasound can fill that void. And I call it POCUS in the house. In the practices that I work with, those patients get scheduled directly with the clinic that they're preferred, that they already attend. And I see that patient for the examination, and in that examination, when performing all the testing that I need to do, I decide if they need to have the musculoskeletal imaging. And patients that are walking in that day can actually be referred immediately from the doctor in what I call walk-in possibilities. I perform that evaluation right there in-house. And this brings up something. I want to make a point, and that is that with musculoskeletal ultrasound in the hands of a physical therapist, this is not an end-all tool. This is an expansion tool to what we already have in our toolbox of testing. And anyone who uses ultrasound imaging to be the absolute end-all of testing has done a disservice to our entire community and our patients. Because if we do not do orthopedic testing and do our normal physical therapy exams, we're doing nothing more than normal sonography. And I know some amazing musculoskeletal sonographers out there. If we're going to be using this tool to gain the appropriate recognition as a musculoskeletal consultant, let's do the right thing in the right order. And let's not abuse this tool. Let's do it as an extension to our normal evaluation. However, when it comes to delivering this information, that's probably the most amazing thing of all. The patient is right there with you. And as you do the discovery, they're just as amazed as you are. Or if you do the non-discovery, there are times they're just amazed to be there with you. And we'll talk more about that in my last case study. But it is so much easier to justify what we're going to do if we had the patient with us as they do that, as they find out what's going on. My final case before I wrap things up and we can go to questions is what I call the musculoskeletal work-in consult. This only happened about, 2 months ago. The doctor Oh, by the way, I got to set this up right. I had 45 minutes to make my cue for the ferry. It was I was putting things away in the operative room or in the treatment room, and I get this knock on the door from the doctor, and he says, "Look, I've got this 26-year-old guy. He's got severe right ankle pain. I think it's his Achilles tendon. About 3 weeks ago, he fell from a ladder. We did x-rays. They were negative. So about 2 weeks ago, when we did the x-rays, I said, let's just put you in crutches and see if this is going to improve on its own. And now he's back, Greg, without any improvement. Can you at least have a quick look at this? Now, this is a setup for doing exactly what I told you every therapist who does this shouldn't do, and that's rapidly go to the assessment. However, I did look, and I saw that, yes, there was, in fact, some discoloration, but I palpated his Achilles tendon. I didn't find much pain with palpation, but sure enough, he truly had to use crutches because of the severe pain when he went to put his foot down. So here's the setup for the imaging. I had already, in the month before, found 2 medial gastroc tears, and so I was very familiar with where to put the probe and do the scan. What you're going to see showing up here are the pinnate structures of the gastrocnemius on the top, and you're going to see at below, this is the soleus muscle. And where the 2 of them come together, that aponeurosa right there is where we get our tears for what's known as tennis leg. So I looked at this because I'd seen a few before, and I knew that it domes up with darkness when it becomes a problem and there's a tear, and I just found absolutely nothing. So the next scan I went to, let me see if I can get back to this, was the one which is a long axis of the heel cord or the Achilles tendon. This is the tibial bone at the bottom. These are the flexor tendons here. This is the calcaneus and the enthesis where the Achilles tendon goes and attaches to. So scanning medial to lateral, I was able to identify all of the fibers of the Achilles tendon, and there was no evidence whatsoever of a breach or a compromise at all. So I turned that probe sideways. I looked at, again, the back of the tibia. This is the Achilles tendon up here. Down below here is where the calcaneus starts to, the Achilles inserts into the calcaneus. And as you can watch, I go back up. The soleus starts to form. The Achilles tendon unwinds, goes flat over the aponeurosa. There was nothing wrong with this guy's Achilles tendon or calf area. So I got back to what I should have done to begin with. I said, hey, tell me what actually happened. So he said, well, yes, 3 weeks ago I fell from a ladder. I landed heavy onto my right foot, but it was really strange. He said for the first 3 to 5 days, the only thing that hurt was my back and my butt cheek on the right. He said it wasn't until about day 5 or 6 that my ankle even started to hurt. So I went to see the doctor. I told him I got this severe pain in my ankle that whenever I stand up straight and tall, I get pain going down my calf into my ankle. And sure enough, you guessed it. The rest of the story is he had a lumbar lesion. Now, I will tell you, I will give this to you. It's reasonable for us to say any PT would have been able to discover that with a good history and some manual testing. But I do offer this also. Would that patient have been in total buy-in and confidently stopped using his crutches because he saw those fibers go all the way from his calf down to his calcaneus? And would I, in fact, here's another question. What if in that fall he would have literally torn his gastroc or had a mid Achilles tendon tear? Would I have, with just palpation, been able to know all of the answers to these questions? Now, I'm going to get to the review because I know I'm right at the end of my time. We're PTs. We know anatomy. We stress it. We touch it. We have the greatest practical understanding of real anatomy of any professional out there. We just need to understand the echo texture. We need to float that glass bottom boat probe over tissue and learn. We need to explore what things look like and say to ourselves, what else is possible? What can I see? Now, any PT, any DPT, I think any PT can learn and deliver musculoskeletal value to their patients. However, if we're going to be credible sonologists, if we're going to be people who deliver diagnostic testing to our community. I had better stand shoulder to shoulder with the other professionals out there because this tool is ours to lose. We need to be fanatical about our preparations and practice and passion, but you can do that. I'm evidence of that. Critical musculoskeletal diagnostic information can take weeks to obtain and process with our patients. I offer for you. Work with me and let's fill this void of diagnostic musculoskeletal information delivered rapidly and relevantly to our patients. Isn't that adorable? That actually is probably, he could likely be the video that was the poser for my son, because that's Kona's baby. And I turn this now over to Ashley to help us get some answers in if I can. Do I stop share or do you take this over?
I will go ahead and take the screen over.